Hi, this is Brian Kim. I want to share with you case number 219 in the best way to do cataract surgery series. This is a dense white chalky cataract. You're going to see terminal and cross chop as well as mechanical fracturing techniques. And because this is a white cataract, you're going to have a much more clear idea. You can physically see what's actually happening with the terminal chop, cross chop, mechanical fracturing concepts and principles on how I'm able to leverage mechanical forces to disassemble the lens very effectively and safely in this dense white chalky cataract. So you can see this is a dense white cataract. You can see those little radial lines within the lens. I use a corneal mark which will help me to center and size the rexus. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine. And then some intracameral air, and then now some trypan blue. You can see the pupil is a little bit medium size. I put a lot of epinephrine there to see if I can just widen the pupil a little bit, stabilize the pupil, but it didn't really change in size there. And you can see because of this dense cataract, I'm having some shallowing of the anterior chamber. That's why my bubble came out. I normally don't like to leave the dye coating the corneal endothelium, but then I was able to get a nice big bubble at the very end there. Go ahead and start on the contra-incisional side, and then I push dispersive viscoelastic, which pushes the bubble out as well as the dye. This flattens the anterior capsule as well and coats the cornea. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. And these are the microforceps, the sharp tip ones. I puncture the center. And I could tell immediately this is not an intumescent lens. I don't have any milk coming out. I puncture the center. You can see the tear went off to the side. But with these nice forceps, these microforceps, I'm able to grab the flap very easily. I have minimal OVD egress. I have excellent control. I don't have to apply any centralization forces as I do this. I'm able to go around circumferentially, and there's very little radialization forces as I'm doing the rexus. Again, you can see this is a little bit of a smaller size pupil, and I'm using that in order to help me in guiding the size and centration of the rexus. Finish off the rexus, burp some viscoelastic out. Go ahead and remove some of those bubbles. And this is going to be the capsule fornix hydrodissection technique. I slide the cannula under the rexus edge contra-incisionally, point the tip down. I can't see the wave, of course, but as I push it, I lift the lens up, which decompresses the bag. I push the lens back into the bag, and of course the lens begins to spin. In all of these white cataracts, the lens is essentially disassociated from the bag, and it works very well. Again, I've never had trouble spinning the lens in this context. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. I'm going into the dense cataract setting just to be sure. I turn the bevel back up, and then I begin to sculpt. I sculpt in the dense setting, and you can see there's quite a bit of density to this lens. I'm creating a groove, about a 6 millimeter groove. Again, trying to remove that dense central core. If I can cut through that dense central core, then I'll be able to avoid the posterior plate phenomenon. I turn bevel back down, and then I switch to quad mode. I place the chopper under the rexus edge contra-incisionally. I fracture the terminal side, and then I keep splitting and separating, and it fractures it through and through. I place the chopper sliding it sideways under the right heminucleus, turning it vertical, and then I fracture the lens against the phaco tip. That is a cross chop. You saw that sudden loss of resistance. That was a really dense piece there. grabbing that first quadrant with some vacuum, and then crushing the lens with opposing forces between the instruments, and then emulsifying the lens pieces. Loosening up that second quadrant, separating it from the rest of the lens, performing another cross-chop maneuver. You can see how elegant and clear the cutting of the chopper is. It's like a cheese wire, cutting the lens against the phaco tip like a chopping block. Again, performing more mechanical fracturing forces to crush the lens into smaller and smaller pieces, and then emulsifying the lens pieces using sparing amounts of ultrasonic energy and vacuum. Again, crushing the lens primarily, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, placing the chopper around the lens, and then crushing the lens and amputating it in half, again with another cross-chop maneuver. Doing the same thing with the third quadrant, crushing the lens against the phaco tip with the chopper, and then emulsifying those lens pieces. Again, when you're having disassembly of the lens in this way, you have excellent control. You're just using infusion pressure, and then you're just crushing the lens with the instruments. And again, when you're having just this, again, no epinucleus, no protection, in these contexts, it's even more important to be able to leverage mechanical fracturing forces, because the posterior capsule can come right up. I have no protection, but do I care? Am I worried? No, not at all, because all I'm doing is maintaining infusion pressure with irrigation fluid, and then I'm using my instruments to crush the lens pieces. Only when I'm ready to emulsify the lens pieces, I go ahead and start eating the pieces, but I make sure that there's a big piece of lens material that's blocking the posterior capsule from coming up, and or I have the chopper deep so that I protect the posterior capsule from the phaco tip. This is the last fragment. Again, I'm positioning it and sliding it in such a way that I hook the peripheral lens with the chopper, and then I crush it against the phaco tip, which fractures the lens piece. I'm carefully using a little bit of vacuum to grab that piece, position it, and then crush the lens into smaller pieces. Again, there's no protection. Very, very important in these cases to have good protection. And why do I have good protection? Because I'm using sparing amounts of vacuum in this context, and I'm primarily focusing on mechanical fracturing forces to protect myself when I'm disassembling this lens, especially when I have only a few pieces left. Very, very important pearl, and why I do this surgery this way. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I remove any remaining cortical material, which is rather limited. So I switch to polish mode, polishing underneath the rexus edge, and then switch to cortex mode to remove any remaining material. And that's a nice thing. I can switch from polish mode to cortex mode very quickly using my foot pedal control, so I can remove that cortical material very gently with polish mode, and then clear the tip using cortex mode. As you can see, excellent control with polish mode. I'm not damaging the zonules. I'm not grabbing the capsular bag, even though it's a little bit of a blind pass as I do this. Pulsing BSS into the subincisional capsule fornix, and you can see there's a bunch of stuff comes out, a lot of stuff. And so that maneuver works very, very well. Yes, you can use bimanual, but then you're using metal tips, and I like the polymer tip better. And so I like to pulse with the subincisional capsule fornix with the BSS cannula. I go in with the cohesive viscoelastic cannula, deactivate the infusion pressure, push the cohesive viscoelastic to fill the bag, and then I'm sweeping with the polisher, sweeping underneath the left side and then the right side, removing lens epithelial cells and any loose cortical material that may be there. And then I'm going to widen the incision with the blade here. And with these dense cataracts, I prefer putting a 3-piece lens in just to be on the safe side. So widen the incision a little bit. Again, my incision is 2.6. So I have to widen it a little bit more. The haptic's sticking out a little bit, and I know that wasn't intentional. So I'm going to go in sideways so the haptic goes in first so I don't bend it accidentally. And then I put the injector in, very carefully just sliding it in. Good. So the haptic is nice and safe. It hasn't been crimped. I rotate the bevel to the left, deliver the leading haptic into the capsular bag. But before I do that, I'm going to push some more cohesive viscoelastic to fill the bag. I'm just waiting on the viscoelastic here. Here it comes. Pushing more cohesive viscoelastic to fill the bag. I don't want any stria. I don't want any collapse of the capsular bag as I put the lens in. Very important with these 3-piece lenses. Go ahead and deliver the leading haptic into the bag, allowing the optic to open up planar, making sure the trailing haptic is faced to the right, and then using the Maltzman to dial the trailing haptic into the bag. So with the INA handpiece, I go in with irrigation off, activate irrigation, quickly get underneath the lens before irrigation stops, removing all the viscoelastic from within the bag, repositing the optic back down. And again, because I widen my incision, I have more fluid coming out of the incision, so I have less chamber stability. So it's very important that I am mindful of this as I'm finishing up. Polish under the rexus edge, and then I'll remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, the biggest pearl in this case, again, white cataract. There's absolutely no epinuclear material, nothing to protect the posterior capsule. And when I have only 1 or 2 quadrants left, there's a risk that the posterior capsule can come forward. And so don't use high vacuum. That's when you should use less vacuum in that context. But oftentimes the lens fragments are flying around. You're trying to grab it. So what do? You go after with high vacuum. That is really poor technique. Instead, you saw what I did. Maintain high infusion pressure, and then position the instruments, your phaco tip and chopper, around the lens, crush it into smaller and smaller pieces using mechanical forces. And then when you're ready to eat the piece, make sure there's another fragment between you and the posterior capsule. And if you don't have a fragment, then just place the chopper deep and then very carefully pulse ultrasonic energy and vacuum to remove the lens pieces. So that's my biggest pearl. When you have loose lens pieces and you have a posterior capsule that's very exposed to you, don't do any of this other stuff with high vacuum. It makes no sense. Again, use only mechanical forces to crush the lens into smaller and smaller pieces. By doing it this way, you're not using vacuum, therefore you're not going to encourage the posterior capsule to come forward. Once you crush the lens pieces into smaller pieces, you can try to create a barrier with another lens piece as you emulsify those pieces, or place a chopper deep as a barrier to protect yourself from the posterior capsule. In order to protect the posterior capsule from the phaco tip, emulsify those lens pieces, and you can have a very safe, calm, easy way to disassemble the lens, especially in a dense, white, chalky cataract. So I hope this was helpful to you, and I thank you for your attention.